Okay, so the first thing we'll do is sacral base, but you can just reference my Cat 1 or my Cat 2 video, and you're good there. Glute fiber analysis. Patient's prone. Glute fibers relate to the lumbar spine. I'm going to correctly identify the PSISs, and then evenly, PSIS, and something, I don't know, I'm going to go from L5 to L1. Anyway, so it's going to start L5, L4, L3, L2, L1, rotating out along the crest. If it's still tender after Cat 3 blocking, I'm going to treat it as a trigger point. So SOTO, I am going to have the patient prone, and this is an indicator for sciatica. It's diagnostic and therapeutic. I'm going to sit on the side of involvement, and I'm going to bring the leg lateral 14 inches or until the glute bunches, and hold it for 10 to 15 seconds and wait and repeat. So, externally rotate, the apple. And then I'll ask the patient if it's better, worse, or the same. If it's better, it's a piriformis problem. If it's worse, it's a sequestered disc. If it's the same, it's a subluxated or herniated disc. And I'm going to repeat that every 2 minutes if it's a piriformis problem. Cat 3 blocking. The block's 4 inches above the iliac crest. Sternum rolls in place, and the blocks are going to go on the short leg side at the trochanter 45 degrees inferiorly, say it. On the long leg side of the ASI, 45 degrees inferiorly. My goal is to reduce pain. I'm blocked for 30 minutes, so come back in 30 minutes. Alright, it's been 30 minutes. That's good. That's what the patient said. So now I'm going to go on to the posterior iliofemoral ligament. And I'm going to internally rotate, look for restriction. I'm going to say the left is more restricted. I'm going to go to the iliofemoral ligament, and I'm going to go like that to the other side until I feel a release. Lumbar, vertebral, vertebral derotation. Patient's going to be blocked for Cat 3. You can traction the head of the table. Don't worry about it. I'm going to flex the patient's knee to their butt, and I'm going to go to the involved vertebra, and I'm going to go from lateral to medial. And if I was doing the lumbar inferiority lift, it would be the same thing, but I'd be on the TVP or the mammillary process, and I'd go from I to S. If this was acetabular goading, I would go to the acetabulum and look for nodules, and I would just hold pressure on the nodule while keeping the leg flexed as well and moving in circles until I feel a release. Orthopedic blocking, I would just pull the block on the side of the involved spinous. That's pointing away to derotate the vertebra. Sciatic traction. It's an indicator for sciatica. Patient's tractions the table, and I would traction the sciatic leg for 5 to 10 seconds, and I would repeat until there is no more improvement. Sacral cup. Patient's prone, not on blocks. Patient raises and tries to keep the leg elevated against doctor's resistance. Where's your leg? It's weak. So if the patient can't do it, I would go to the sacral cup between S1 to S2 or S2 to S3, and then I would recheck again, and then it's strong. And then depending on if it was S1 to S2 or S2 to S3, I would adjust with a double thumb toggle. Sitting disc, can you sit up, sir? And yeah, just face that way. So for the sitting disc, I would have the patient, you're going to tuck your chin to your chest, you're going to inhale and flex forward, and I would go I to S on the vertebra, and you exhale and then come back, and I would go I'll press PA on the involved vertebra, and then I'll do it again 3 times. And then you're good. So side posture is for sciatica, and the patient is on his side with the sciatic leg down. For a rotated vertebra, the spinous must be down. For a tip vertebra, the inferior TVP must be up. I would contact the mammillary, fingers pointed up the spine, and my line of drive would be P to A, I to S. And I will demonstrate that, but there's not a doctor present, so I'm not allowed to adjust. That's it.